Welcome again, everyone, to this third and last of our little series, introductory series on cardiac angiography for year one of your units on the cath lab. In this lecture, we're going to be looking at the basic angiographic views, the standard echocardiographic views, focusing on lab structure, viewing angles, and throwing in a little bit of coronary angiography as well. My name is John Boland. And for those of you who may not know, this picture shows you a schematic of a cath lab, basically an X-ray machine that takes coronary and cardiac images of a patient lying on a table. First, let's have a quick look at the differences between echocardiography and cardiac catheterization. They're both modalities for looking at cardiac structures, for imaging cardiac structures. Going through echocardiography, first, it's a one-man operation. You're one-to-one with a patient, whereas the cath lab is a team effort involving cardiologists, nurses, techs, and a whole stack of other staff. We're both examining cardiac structure and motion on a live patient. We're focusing on valve anatomy and function to diagnose pathology, particularly valve disease and coronary artery disease. We both perform calculations such as valve areas, flow analysis, cardiac output, flow, and the differences arise in the actual mechanism of imaging. In echo, you use ultrasound, which is a non-invasive procedure, and that's basically it. Whereas in the cath lab, it's a highly invasive procedure requiring X-rays, and that brings in a whole new dimension. It requires a special dedicated laboratory with protective shielding capacity and restrictive entry and many other factors, as you do in radiology laboratories. The principal mainstay of cardiac catheterization labs is imaging coronary anatomy for treating coronary artery disease, one of the biggest killers in our society. And it can incorporate different modalities. We can have echo images imported while we're screening. We can import CAT scans and other types of modalities to assist in the interventional side of the procedures, which is probably the major difference between the cath lab and the echo lab. Echo lab is diagnostic. The cath lab is also an interventional laboratory. And in this instance, sterility becomes predominantly important, just like an operating theatre, a surgical environment. That's just a brief recap about the differences between a cath lab and an echo lab. This is an example of the kind of imaging we obtain in a lab. This is one of our older models. You can see we have a battery of X-ray screens where we can also access monitoring systems with pressure and an ECG you can barely make out possibly, and auxiliary equipment that we bring in. This, for example, is an IVUS machine, intravascular ultrasound, using the same sort of principles as an echo machine, but on the inside of an artery, rather than, say, an ultrasound probe on the chest or an ultrasound probe down the esophagus, ultrasound based. In terms of interpreting our anatomy, we have similar but different problems in terms of recognizing our intracardiac structures. This is an example of what you either already know or will know in detail very soon. It's a representation of the three basic planes of cross-section that you image when you do a two-dimensional transthoracic echocardiogram. It has three orthogonal cross-sectional views. You'll see this slide more than once, and it nicely shows you the orientation of the heart in a patient's body, but it doesn't lie in the same cross-sectional planes as a standing human body. It has two vertical planes, the short axis and the long axis plane, and a third horizontal four-chamber plane that bisects the heart horizontally. And from that, you can obtain your standard echo images, which still takes a lot of understanding and a lot of practice. And it's important to retain our frames of references in that we still refer to anterior and posterior views. Just bear that in mind as we proceed because it has relevance to the angiographic planes that we see in the cath lab because we look at the heart from different angles altogether, even though we're viewing the heart from basically the same external perspective. This is a shot of one of our newer machines showing you the U-arm system with the X-ray generator below coming through to image receiver above the patient. So the X-rays are generated from below the patient and the images are received above the patient. This is called the straight anterior-posterior view, very much like a chest X-ray. And the machine can rotate around the patient sideways and caudally or cranially towards the feet or towards the head. So we have a full, almost hemispherical field of view of the patient, focusing on his heart, of course. And here you can see the rotation going to the patient's right. Our left, but it's the patient's right-hand side, just like in an X-ray, a chest X-ray. And this is called the right anterior oblique view, simply an angular shot from the patient's right shoulder. And the opposite of that is the left anterior oblique view, still in the same plane of cross-section for all these three shots, but this time the image receiver is on the patient's left-hand side. Our orientations in cardiology are taken from the point of view of the receiver, whereas in radiology, the perspective is taken from the point of view of the X-ray source. So to radiologists, this view would be the RAO, just to confuse things, and conversely, this view would be the LAO for the radiologist. You have to be aware of the differences because you will probably relate to both fields of study from time to time, and it can be confusing. Just remember in the cath lab, the X-ray generator swings from side to side and head to tail, and each view has a name. This is the kind of image on the left-hand side of our screen, the RAO, as we see the heart. Heart's in sinus rhythm, and that's a ventriculogram, an angiogram of the ventricle showing dye going through the aorta. On the right-hand side of the screen, which is the patient's left-hand side, this is the view we get of the heart from the LAO, and you can see they look totally different. This is an aortogram, so the dye that's injected into the patient to visualize these soft structures is used to show the cavity of chambers, such as the heart, such as the ventricle, the atria, in this case, the aorta. In this case, the ventricle, which also lights up the aorta. Try to appreciate the difference in that, in the same way that you change the angle of an echo probe, if you change the angle of these X-rays machines from left to right, you get a totally different view. Here you're looking at the heart sideways, from one lateral side to the other, from the right side of the patient, the RAO. This time you're looking at the patient from the left side, the LAO, and you're looking at the heart end on. It's like a football standing end to end, pointy end pointing towards you and down into the screen. You'll become familiar with these eventually. This is an introduction to prepare you for what we will be teaching you later on. Importantly, the coronary anatomies fit in specific locations around the heart. And if you look at the heart on its side, as shown by this wire, that shows you the LAD and the circumflex in these angles. If you look at the wire cage end on, this is that second shot we saw on the previous side, looking at the heart end on. And there are slight variations on this where you tilt that end on position here to localize different parts of the coronary arteries. It's a very big learning curve to familiarize yourself with these angles, just to show you that unlike echo, we look at coronary arteries as a big part of our lives. To make it easier, I'll show you a few AVI files. This is a shot of a ventriculogram. Again, this is the right side of the patient, the RAO, with a catheter sitting inside the left ventricle, pumping dye that lights up or darkens the internal structures of the ventricle under X-rays. We can't see soft tissues under X-rays, but when we inject the dye shows black under X-rays and lights up all the inside of the cavities. That's the ventricle pumping blood straight through the aorta, up the ascending aorta, and back down the descending aorta. Looks nothing like the echocardiograms, but you can, I think, see the similarities. And if you're familiar with your anatomy, you'll recognize that as a ventricle, which you would also see in echo, but from a different perspective. This slide now is the ventriculogram in the opposite direction, the LAO. And you can see this much clearer image. The catheter now is at the aortic root, but this patient has a leaking valve, and so the ventricle fills across that leaking valve from the aorta into the ventricle. I'll play it one last time, just to show you the difference in orientation, and you can see the coronary arteries lining up as well. This is now a right atrial angiogram. So we're looking at the right side of the heart now. Those previous two slides were the left side. This is the right atrium, which pumps blood into the right ventricle, crosses into the pulmonary artery, dissipates into the circulation, so the dye flattens out, and then it comes back to the left atrium and then into the left ventricle. And it was cut off before it went back into the aorta. I'll play it again, try to follow that sequence. The dye thins out, so you lose the picture. Then it comes back to the left atrium from the lungs via the pulmonary veins, fills the left ventricle where this catheter is, as in the first slide. I'll play it through one more time. Catheter in the right atrium, filling the right atrium, going across the right ventricle into the pulmonary arteries, dissipates through the lungs. Dye comes back, concentrates in the left atrium, fills the left ventricle, and then it goes back out through the aorta. You can see it at the very end. I'll stop it at the end of this run. That's just to familiarize you with what goes on in the cath lab, to give you an idea of what to expect in terms of imaging, the differences between the cath lab and the echo images you're by now pretty familiar with, or if not, will soon be. This is another one now, but of a coronary artery. So you have seen the left ventricle from two views. You've seen the right heart, right from the right atrium all through to the pulmonary circulation and coming back to the left heart. We're now going to look at a coronary artery. And you can see or maybe imagine a three-dimensional structure in there. The trick to understanding these is to visualize in your mind something like a football or a heart shape, with this as the seam of the football and the arteries coursing around different aspects of it. If you can't, don't be concerned, it takes time and practice. But by building these three-dimensional images in our minds, we can construct a view of the cardiac anatomy. This is a normal left coronary artery in what's called the RAO cranial views. The third of that shot I showed you of the little wire cage. We'll move on. This is a close-up still, shows you the catheter at the root of the coronary artery injecting the coronary artery, the left coronary artery, and you can see fine branches. There's little differences in opacity, they're artifact. That opacity depends on the thickness or the density of the dye coursing through the vessels, and it can vary. This shot is taken near the end of the run, so we're starting to lose dye. This is still showing you an interpretation from a slightly different angle, showing you the presence of thrombus. This is the kind of pathology we look for, either narrowings, occlusions, or foreign bodies of some kind in the left coronary artery that can obstruct, or in any artery, in this case the left coronary artery, that can cause obstructions, lead to chest pain and a heart attack, and possibly death. This is a left coronary angiogram showing you the presence of two stents in the left coronary artery. It's the same shot as before, fixing that thrombus, but I'll play it. So this is a shot without dye. You can't see the coronaries, but you can see shadows of the heart moving. There's the catheter into the coronary artery, and we have placed two stents, two overlapping stents in the branch where that thrombus was in the previous patient. I hope you can appreciate that. Again, it's only intended to demonstrate the possibilities, the differences in imaging. You will not see coronary arteries routinely in echoes. You might see a big vessel from time to time, particularly at the origin of the left main, but that's pretty much about it. You will not likely visualize coronary arteries. We started off with the left ventricle. We went to the right side of the heart. We then started looking at coronary arteries. You saw moving images and stills of the left coronary artery. The other coronary artery to the heart is the right coronary artery. It's a simpler vessel. You notice it arises on the left side of the screen, which is the patient's right, whereas the previous shots of the left coronary artery arose on the right side of the screen, which is the patient's left. Hence, left coronary artery, right coronary artery. This is a shot very much like that second shot I showed you at the very beginning, and this time there is no leakage back into the ventricle, so you can't see that circular portion filling with dye. The dye is going in the same direction. The aortic valve stops that flow. But if you look very closely, you can see the opening of the valve and only one leaflet is moving. You know there are 3 leaflets to the aortic valve. You can see the 3 aortic cusps containing the sinuses, and the blood coming from the ventricle only has a narrow opening to course through. This patient had a stenosed aortic valve, which you can only appreciate if you know what to look for, but it's part of a valve investigation. The first patient of this view that you saw had a leaking aortic valve. This patient has a tight valve. The difference between a stenosed valve in this case and a regurgitant valve in the first case. Again, just try to appreciate what happens. Relating your echo cross sections to our coronary anatomy, you'll see they're totally unrelated. Again, this is one of the standard cross-sectional views in your echo studies, the short axis. In other slides, you'll see the rest. I included them all in the heading, but you can see the cross-sections through the heart and what they look like in your ultrasound images, as opposed to our coronary artery images in this case, and how we have to visualize the entire structure selectively with injections, and you visualize sections of the cardiac structures selectively at different angles of cross-section. Here you can see some similarities. That's the only way we can see the ventricle, except in 2 different views, as you've seen, whereas here you can see different cross-sections of your echo images. But you can relate the structure, except that here this is only the left ventricle, whereas here you can see all the other chambers. And yes, of course, you will memorize all these labels and views and angulations in your echo life, and you will immediately recognize them, as you would in the cath lab. Comparing again, this is the M-mode long axis scan, where you visualize and measure all these structures in a sweep from the apex to the base, going through both atria and ventricles, and you pick up valve movement. Compare that to the angiogram of the left ventricle on the right. So moving on, this is what you will be seeing in your echo views probably and hopefully for the rest of your working lives. This is your 2D echocardiogram. This is a parasternal long axis view. Can you identify each chamber? Have you been exposed to echoes long enough to identify that? Whether you have or not, you can identify this as the left ventricle. The chamber that comes off the left ventricle is the left atrium. Therefore, this has to be the mitral valve. Your orientation is important. Your right ventricle sits above your left ventricle, and your aorta sits in between, and this is clearly identifiable, hopefully, as the aortic valve. You will become familiar with these names. It's expected of you. And in relating this to the patient, this is the tail of the patient, of the feet, and this is the head of the patient. So you'll be able to interpret this in terms of anterior and posterior and superior and inferior. Let's have a look at the answers on the next slide, except to point out it's not very clear here. This would be the aorta. So here we have that. Right ventricle, the uppermost structure, the interventricular septum. I guess I should have pointed that out in relation to the posterior ventricular wall, where you can see pericardial fluid if you have pericarditis. The descending aorta is shown more clearly here. And you have the left atrium here, posterior mitral valve leaflet and the anterior mitral valve leaflet, left ventricle and aorta separated by the leaflets right here. Let's look at that apical 4-chamber view. Left ventricle, right ventricle, and often you will see that moderator band in the right ventricle. The dimensions will matter. You'll have to measure the ventricle and the dimensions of the cavities. Obviously, left atrium, right atrium. And sometimes you can see the pulmonary veins coming off the left atrium. These are the mitral leaflets, and these are the tricuspid leaflets. Again, I'm sure these will become second nature to you in time. And finally, we'll come to this last slide showing you the answers to the question on the previous slide: left ventricle, right ventricle. MB is the moderator band, right atrium, left atrium. And you will notice your orientation will also change slightly, in that here we now talk about right and left and inferior and superior, because now you're looking at that horizontal transverse plane of cross-section. So your orientation relative to your standard anatomical planes will be different with every angle. That ends this lecture. This was just a brief introduction of what images we expect to find in the cath lab and in comparison to the images you find in the echo lab. You will hear more about cath labs as you proceed with your 3 or 4 year course that hopefully will end up in your becoming fully fledged echocardiographers. But in the meantime, in between now and then, there is much to learn about a lot of different things. So I wish you well, and I will now end this presentation.